the organizing persons, especially Dr. Kumaravel and Aruna, for giving us this opportunity to be with you all. I like to introduce Dr. Gurulakshmi Murthy from Chennai. She is the alumni of Madurai Medical College and she did AB Internal Medicine in the University of Illinois in USA and endocrinology, diabetes, metabolism in Indiana University, USA. And she is a consultant endocrinologist in Gleneagles City and Dr. Kamashi Memorial Hospitals in Chennai. Her achievements are so many. She got Dr. Richard Schunat Award for Clinical Excellence in India from Indiana University, USA, and Excellence in Quality Care by Piedmont Hospitals, Georgia in 2018, and facilitator and organizer of case conferences in Piedmont, Georgia until June 2023. Welcome you, ma'am.
Thank you very much, ma'am. So, I'll be discussing polycystic ovarian syndrome, phenotypes and clinical implications. Polycystic ovarian syndrome is the most common endocrine condition in the reproductive domain, and it is a complex disorder reflecting interaction between various genetic and environmental factors. The prevalence is around 5 to 15% worldwide, and it is even higher in India, around 10%. Now, I'll start with a case. 22-year-old female comes to the clinic with irregular menstrual cycles, and she also has excess facial hair, and she was diagnosed with polycystic ovarian syndrome, and she tells me that she had an ultrasound pelvis done 2 years ago and was told she had bilateral polycystic ovarian morphology. Now, she also has a history of celiac disease. She complains of weight gain 10 kilograms in the last 1 year. She weighs around 70 kilograms. She's obese, BMI is 31. Waist circumference is around 34 inches. She doesn't have any Cushingoid facies, has central obesity. She doesn't have any clitoromegaly, acanthosis present, has a Tanner stage 5 breast bilaterally, and family history was significant for mother who had polycystic ovarian syndrome. Little details about the menstrual history: had her menarche around age 30. She did not have menstrual cycles for the first year, and after that she has menstrual cycles every 35 to 40 days. Now, is this irregular menstrual cycles? So let's see what the guidelines has to say. The International Evidence-Based Guideline in October 2023 says if you are within 3 years post-menarche, the menstrual cycles are irregular if it happens less than 21 or more than 45 days in duration. If you are more than 3 years post-menarche, then irregular menstrual cycles are defined as menstrual cycles less than 21 or more than 35 days. So now this patient has irregular menstrual cycles according to the guidelines. Now going on to the hirsutism, she has a FG score of 8. This is a visual gradation of hirsutism. She doesn't have any acne but has some generalized hair loss. So the guidelines say hirsutism is excess terminal hair growth, dark coarse hairs in androgen dependent areas, and this is a good marker for hyperandrogenism. Isolated acne and alopecia cannot be a good marker for hyperandrogenism like hirsutism. Now, when you have clinical hirsutism, it has to be evaluated biochemically. So, what do you order? Next, we have total and free testosterone. So, you cannot just order a total testosterone since SHBG can be low, and so total testosterone can be normal and the free testosterone can be high. So, you can either estimate the free testosterone by calculating a free androgen index, or you can measure it by equilibrium dialysis or ammonium sulfate precipitation. Now, when the testosterone comes back normal, then you order androstenedione and a DHEAS. But we have to keep in mind DHEAS has a very poor specificity and it also declines as you age. Now, the guidelines favor mass spectrometry assays over enzyme-linked assays. Now, going on to the next one, which is the ultrasound characteristics. Follicle number per ovary is the most effective marker to detect the polycystic ovarian morphology. If it is more than or equal to 20 in at least one ovary, then you can say it is PCOM. If you are using older technology, then ovarian volume more than or equal to 10 ml or follicle number per section more than or equal to 10 in at least one ovary is considered polycystic ovarian morphology. Now, next about serum AMH, which has been a talk in the diagnostic criteria. Now, serum AMH can be used in place of ultrasound characteristics, but you cannot use it alone. When you have a patient presenting with ovulated dysfunction and hyperandrogenism, then you do not need AMH to diagnose polycystic ovarian syndrome. And this cannot be used in adolescents since serum AMH is very high in the adolescent period. And usually, if it is more than 10 nanogram per deciliter, then you can consider that as a PCOS. Now, what are the diagnostic criteria that we have? In brief, we have NIH and then Rotterdam and then Androgen Access Society. Now, in 1999, we have the NIH criteria where you have to have chronic anovulation and hyperandrogenism. And then the Rotterdam criteria came in 2003 where you have to have oligoanovulation plus hyperandrogenism and or polycystic ovaries. Now, both of these criteria say you have to exclude other etiologies before you diagnose PCOS. Androgen Access Society, in contrary, they have to have hyperandrogenism and you can have ovary dysfunction and or polycystic ovaries. And here also they say exclusion of other etiologies before you diagnose polycystic ovarian syndrome. So let's talk about pathogenesis in brief. The pathogenesis is still not very clear, but most of the studies agree there is increased frequency of GnRH pulse, which favors the LH production, which stimulates the theca cells here and leads on to increased ovarian androgen production. Now, the increased functional ovarian androgen also takes away the negative feedback of progesterone to GnRH, leading on to more increased frequency of GnRH pulse, and the cycle goes on. Increased insulin also decreases SHBG, thereby resulting in increased free testosterone. Now, back to our patient. Can we confirm that she has PCOS? So, we saw all the guidelines said we have to rule out other etiologies before we confirm PCOS. So, we'll see those in detail. And then going on to which phenotype does she fit into? So, here are most of the differential diagnoses for a patient presenting with hyperandrogenism and ovulated dysfunction. Hyperprolactinemia and hypothyroidism are most commonly associated with PCOS and can also present like polycystic ovarian syndrome. Then comes the non-classic congenital adrenal hyperplasia. So you can think non-classic congenital adrenal hyperplasia can present with like lots of hair and virilization, but non-classic congenital adrenal hyperplasia can present a similar way to PCOS. Now, next we have Cushing's acromegaly, virilizing adrenal or ovarian neoplasm, and then we have POI, which Dr. Shruti will talk about in the next session. So these are some of the clinical features that can point towards your diagnosis, differential diagnosis, when you have a patient with hyperandrogenism and oligoanovulation. The first one is the most important one because it just mimics polycystic ovarian syndrome. Non-classic congenital adrenal hyperplasia. You can look for a family history of infertility, hirsutism, or both. Now, why is it important to differentiate polycystic ovarian syndrome from non-classic congenital adrenal hyperplasia? Because these women can transmit the full classic congenital adrenal hyperplasia to the offspring. And when you are doing ovulation induction, they might need glucocorticoids for that. So when you suspect non-classic congenital adrenal hyperplasia, you order 17-hydroxyprogesterone, 8 a.m., early follicular phase if they have irregular menstrual cycles, if they have regular menstrual cycles. If they do not have menstrual cycles, then you can order random early morning 17-hydroxyprogesterone. If it is more than 200 nanogram per deciliter, then you do a screening, confirmatory test, which is the ACTH stimulation test, and if it is more than 1500, then you confirm non-classic congenital adrenal hyperplasia. And then Cushing syndrome, they can very well present with menstrual irregularities and hirsutism. Now, you have Cushingoid features if you have Cushing syndrome. Not every patient has to have Cushingoid features to diagnose Cushing syndrome. So Cushingoid features such as moon face shapes, truncal obesity, and then they can have diabetes, hypertension, easy bruising, all those things. And a screening test would be a dexamethasone suppression test, and then you confirm it with 24-hour urine free cortisol and or a salivary cortisol. And then we know about hyperprolactinemia and hypothyroidism. You order prolactin and thyroid function. Now, if you have a woman who comes in with rapid onset and extreme form of hirsutism and signs of virilization such as clitoromegaly or deepening of the voice or male pattern baldness, then you think about virilizing adrenal or ovarian tumors. Then next, going on to our main topic, which are the phenotypes. So we have 4 phenotypes. Phenotype A, which is the full or classic PCOS, where you have hyperandrogenism, anovulation, and polycystic ovarian morphology. And then phenotype B, where you do not have polycystic ovarian morphology, but you have hyperandrogenism and oligoanovulation. Phenotype C is otherwise called ovulated PCOS because they do not have regular menstrual cycles. They have a polycystic ovarian morphology and hyperandrogenism. Phenotype D is non-hyperandrogenic PCOS, where you do not have hyperandrogenism, but you have oligoanovulation and a polycystic ovarian morphology. Now, A and B, where you have hyperandrogenism and ovulated dysfunction, are called NH phenotypes, and phenotype C and D are called non-NH phenotypes. Now, why do we have to differentiate all these phenotypes? Does this have any clinical implications? And is it going to change the management? Now, bear with me, I'll go through a couple of, bunch of studies because we don't have anything about phenotypes in the guidelines. So this is a multi-center study of 2,000 plus women in Netherlands and published in Fertility and Sterility in 2014, where they classified PCOS women into hyperandrogenic and non-hyperandrogenic PCOS. And they looked at all the metabolic profiles such as weight, insulin resistance, hypertension, lipids, and also waist circumference. And they saw clearly hyperandrogenic PCOS was associated with an increased prevalence of cardiometabolic derangements. Now, these kind of studies was done around the world. This is a Korean study which also did the same thing, and this is an Indian study which was published in 2019. It's a small study, but they also looked at response to clomiphene among the different phenotypes. And this is a recent study which was published in June 2023 in Human Reproduction, and they also did the same thing, like different phenotypes and the implications to clinical practice. Now, almost all of them found a similar thing. What did they find? Phenotypes A and B. If you remember, it is the phenotypes with hyperandrogenism and ovulated dysfunction. They are at higher risk of metabolic dysfunction, and it was worsened by obesity. So they definitely need frequent assessment of the metabolic profiles. And the phenotype D, where you don't have hyperandrogenism, was less severe. Now, the Indian study also found that the phenotype A, which is the full PCOS or classic PCOS, were also more resistant to clomiphene and might have lesser pregnancy rates. Now, this is again another study which was done which was published in JCM in 2012. They specifically looked at non-alcoholic fatty liver disease, and hyperandrogenic PCOS was a risk factor for non-alcoholic fatty liver disease independent of obesity or insulin resistance. And here they looked at insulin resistance, and this was also high in the classic group, which is the phenotype A, and the ovulated group, which is the phenotype C. Now then they went for more AMH studies. So they looked at AMH in all the phenotypes, and they found that highest AMH levels were found in phenotype A, where they have everything, where hyperandrogenism and ovulated dysfunction and polycystic ovarian morphology existed. Now, and then they looked at maternal and neonatal outcomes in pregnant women with PCOS. So they clearly found that there was increased risk of gestational diabetes and pregnancy-induced hypertension in all the PCOS phenotypes, and there was no difference between any phenotypes. Now, and then they went ahead and did a large-scale study, which was a meta-analysis of population in 10,000 women, and to find if there is any genetic architecture difference. And they did not find any. So there was no genetic architecture difference between different phenotypes. So then they decided, okay, so let's divide them into different categories instead of these four phenotypes. So these are two studies which was published in 2024, and they differentiated PCOS women into reproductive, metabolic, and diabetic. Reproductive, where you have higher LH, SHBG levels, and relatively low BMI and insulin levels. And they found that this group had the high AMH and total follicle count. And the metabolic group had high glucose insulin levels, and they also found to have high LDL and blood pressure. And the background group did not have any distinguishable pattern. Now, again, after that, they did a genomic study, and they found that they could find different genetic loci for the reproductive and the metabolic group. So we need more information on this with different trials. Now, this is another one where they differentiated into lean and obese PCOS. And the lean PCOS found to have increased LH, total testosterone, and androstenedione levels. And they suggested the lean PCOS hyperandrogenism could be neuroendocrine mediated, and the obese PCOS hyperandrogenism could be more high insulin and insulin resistance mediated. Okay, so I showed you a bunch of studies. Now let's go to the facts. So what do we know now? Phenotype A and B, where you have hyperandrogenism and ovulated dysfunction. They had more menstrual dysfunction, increased insulin levels, high prevalence of obesity, BMI, high metabolic syndrome, and non-alcoholic fatty liver disease. They also had higher AMH levels. So what we know, phenotype A and B are the high risk population for metabolic syndrome. The intermediate, this group was called the intermediate risk group because for the high androgens and for the metabolic syndrome, they were at intermediate risk, which is the ovulatory PCOS or the phenotype C, where they do not have irregular menstrual cycles. Then going on to the phenotype D, where they do not have hyperandrogenism, they had the mildest degree of endocrine and metabolic dysfunction and lowest prevalence of metabolic syndrome, lowest testosterone levels, and higher SHBG levels. So they were termed as low risk for metabolic syndrome. Now back to our patient. So we evaluated her with prolactin, estradiol, FSH, LH, thyroid functions, and then HbA1c, fasting insulin. Prolactin was high at 46.3, and we repeated fasting prolactin, that came back to be normal. LH was slightly high at 22. And we did a total testosterone, which was high at 65, and a free testosterone was significantly high at 15.3. And the 17-hydroxyprogesterone was 150. If it is more than 200, then you will do a post-entropin stimulation test to look for non-classic congenital adrenal hyperplasia. And then we also did a dexamethasone suppression test in her, and the cortisol was less than 1.8. So now this patient comes under phenotype A because she has ovulated dysfunction, hyperandrogenism, and polycystic ovarian morphology. So she is otherwise termed as classic PCOS. So since she is at higher risk for metabolic syndrome, we need to monitor metabolic profiles frequently. In addition to lifestyle interventions, which is the mainstay of treatment, she will also need combined oral contraceptive to regularize her periods and treat hirsutism, and definitely consider metformin since her BMI is also more than 30. Now, going on to clinical implications. So, we definitely know now phenotypes with hyperandrogenism have more metabolic derangements from the rest of the group. And these phenotypes can become less obvious with age, and obesity can also impact the severity of the phenotypes. Now, they also found increased prevalence of psychological disorders in all phenotypes. And we also know maternal and neonatal complications were similar in all phenotypes. And there is increased risk of gestational diabetes and pregnancy-induced hypertension in PCOS, and it doesn't differ among phenotypes. So, those with hyperandrogenism and chronic amenorrhea may be more resistant to ovarian stimulation and might have lower pregnancy rates, but we need more data on that. And this population will definitely need a screening for diabetes in adolescents and adult PCOS, especially in those with obesity, truncal obesity, and family history of diabetes. And the screening has to be repeated every 3 to 5 years. Now, this is the guideline. We have the recent guideline, international evidence-based guidelines for the assessment and management of polycystic ovarian syndrome 2023. That's what we follow. And in addition to all that being said, 75 gram OGTT, glucose tolerance test, is the best way to assess glycemic status in PCOS rather than a fasting glucose and a HbA1c. If you cannot do a glucose tolerance test, then you go for a HbA1c and a fasting glucose. And PCOS population also have high prevalence of obstructive sleep apnea, and symptoms should be assessed if they have daytime sleepiness or tiredness. They are also at high risk of endometrial hyperplasia and cancer, but routine screening is still not recommended by the guidelines. So, what do we learn from this session? If a patient presents with hyperandrogenism and ovulatory dysfunction, we cannot diagnose polycystic ovarian syndrome without excluding other etiologies, especially non-classic congenital adrenal hyperplasia, which can mimic PCOS in all the ways. So please do a 8 a.m. early follicular 17-hydroxyprogesterone before you diagnose PCOS and treat along that way. So the basic investigation should be a TSH, prolactin, 8 a.m. follicular phase 17-hydroxyprogesterone, and FSH. AMH can be used along with other criteria, and check the free testosterone before concluding hyperandrogenism. Don't just limit just testing total testosterone. Try to classify phenotypes, and that can tell you more about the severity of the disease and can also lead to how to screen for metabolic CV disorders and how frequent you have to do that. Thank you. Thanks for having me. Thanks to the receptor team. Madurai is so close to me. This is where my medicine journey started. Thank you all.
Very short and sweet presentation, actually. And there is one doubt.
Yes, ma'am.
How to differentiate it? What is the difference in management of lean PCOS and obese PCOS? Because there is more troubleshooting in treating lean PCOS. Number two, for the benefit of practicing gynecologists here, what is any role for myoinositol, decainositol apart from metformin?
Okay, ma'am, that is a very good question. Now, lean PCOS, what do we know? From the studies and the guidelines, they do not differentiate lean PCOS from obese PCOS. What about the obese PCOS? Maybe obese PCOS has an increased risk for metabolic syndrome and cardiovascular morbidity and mortality. But the studies did not say that. Maybe it is related to obesity rather than being obese PCOS. So I would manage a lean PCOS and obese PCOS in the same way and treat according to the guidelines. Now, coming on to myoinositol. Now, myoinositol has been a recent trend. I see they combine myoinositol and metformin and come up with tablets. Now, myoinositol studies, we need more studies to put it in the guidelines and put it in clinical practice. Myoinositol can help in metabolic profile along with metformin, but we do not have any data on ovulation induction, ovulatory induction, and regularizing menstrual cycles.
I have a doubt.
Yes, ma'am.
From the studies you have showed, it looked like all the metabolic features related to hyperandrogenism.
Yes.
So, is there any point in putting these girls on long-term anti-androgens, especially OCPs which have a combination of these anti-androgen drugs?
Now, that's a good point. All the studies showed hyperandrogenism was linked with increased risk of metabolic syndrome. And this hyperandrogenism will need a long-term treatment. And but the guidelines still recommend, oral contraceptive is the most effective way of treating hyperandrogenism. You do it for 6 months. If you don't have an effect, then you add an anti-androgen. Does that answer your question?
Yeah, but nowadays we are having this combination of anti-androgen drugs with estrogen.
No, definitely not. So we have to try oral contraceptives and then go for anti-androgen.
Primarily, we do anti-androgens in case of more for cosmetic skin, hirsutism, acne, or regulating the periods. So that's really works. So, and even in case of fertility, a treatment of 3 to 6 months you do see after that stopping the OCPs with anti-androgen agents, fertility increases. So there is a reason, but long term, we don't know. And that's a discussion, quite a discussion between the patient and the physician.
Actually, anti-androgens is a big no for someone who is planning a pregnancy because constraints.
Definitely, it is contraindicated. Anti-androgens should be always given along with oral contraceptives. Never should be prescribed separately by itself. Never ever. They are territory.
Thank you.
Thank you. That was an awesome presentation. Any other questions? Thank you, Dr. Gurulakshmi. I really appreciate it. I welcome Dr. Jyoti Prince to felicitate Dr. Gurulakshmi.